Ladies and gentlemen, uh, good morning or good afternoon. Um, I would like to introduce myself before starting this presentation. My name is Christos Angelopoulos. I'm a maxillofacial radiology consultant at the Bronx VA Hospital. I'm a board-certified maxillofacial radiologist and the executive director of the American Academy of Oral Maxillofacial Radiology. I have presented a few times at CareStream 3D symposia, and I am really honored to present to you the anatomy and pathology of the maxillofacial region in my today's presentation. I would like to start with some very basic information before we really get into the real pathology, reviewing the real pathology of the maxillofacial region as an introduction. What do we really expect anytime we do a diagnostic image? We certainly expect that our diagnostic images will show disease. That's why we do the images, right? We would really expect to see a very accurate anatomic relationship of the pathological entity to the surrounding structures. In fact, if you think about it, this may be as important as expectation number one. And last, we certainly expect accuracy. In the current days that our colleagues place implants within decimals of a millimeter from major anatomical structures, we better have very accurate images if we want to really bring such a delicate task to a success. Let's see a classical example of a traditional dental image, a periapical radiograph, and see how close this image is to meeting the above goals that we said earlier. This image shows an impacted third molar and the relationship of the left mandibular canal to its roots. In my opinion, this diagnostic image clearly fails to illustrate the true anatomical relationship between the roots of the tooth and the left mandibular canal walls, and as a result, its usefulness is very low. Let's move to another type of image, a well-made panoramic radiograph, a radiograph which is a very popular diagnostic image widely used in dentistry. Let's suppose that our concern is implant placement on either side of the maxilla or evaluation of the maxillary sinuses for possible sinus grafts. We can see that on the right maxillary sinus we have something that looks like a septation into the maxillary sinus. The maxillary sinus appears to be completely pneumatized, and the overall appearance of the right maxillary sinus is somewhat hazy, which may be suspicious for possible sinus disease. On the other side, as you can see here, the maxillary sinus shows the alveolar ridge shows some height in the premolar location, and then towards the molar location it shows a really steep dive. Again, a septation to the left maxillary sinus cannot be ruled out in that specific region. However, for such a delicate procedure such as bilateral sinus elevation, in my opinion is that this kind of image is really inadequate for the diagnostic task that we would like to have in order to provide answers to such a detailed diagnostic task as implant planning or planning for a sinus elevation. It was obvious that we needed something more, and this is why it came to a great relief of the dental profession when this current fairly new technology, cone beam computed tomography, came into the market and really provided solutions and answers to all the above diagnostic concerns that I briefly mentioned on the traditional diagnostic images used in dentistry. How does cone beam CT works? Cone beam CT includes a rotating X-ray source, as you can see here. includes a digital detector. This detector is no different than the classical digital sensors that you may already be using in your practice for intraoral radiographs. The only difference is that it's much bigger and much faster in its image acquisition, as I will explain you in just a little bit. We have the patient in the middle, and we have a conical in shape X-ray beam, hence the name, ComBeam computed tomography. The X-ray source rotates around the patient's head, completing a full circle, and during its rotation it continually bursts exposures like very short cephalometric images around this patient's head. These images may range in numbers from 270 all the way to 400 images, so almost one image per degree of that cycle. Now all this X-ray data, actually X-ray attenuation data, are collected continually by the detector by means of attenuation data, and they are converted to an electrical signal, the intensity of which varies based on the X-ray energy that hit the detector, and as a result this variable X-ray energy will be converted to a variable shade of gray. If we see it in a little more detail, we will realize that really the heart of the machine is the detector. I'm trying to show here that the detector is composed of several very small X-ray or light sensitive areas known as the pixels of the detector. Now the dimensions of each one of these pixels would pretty much predetermine the specific volumetric area into the patient's head that the attenuation data will be acquired. Now these very small three-dimensional areas or cubes of diagnostic information, if you wish, throughout the patient's head, from now on we will call them voxels. So the dimensions of the voxel that the scan, the dimensions of the voxel that the imaging volume is going to be composed of is going to be determined by the dimensions of the pixels of the detector, as we saw earlier. High resolution detectors currently can acquire voxel resolutions in the range of 0.08 millimeters to 0.2 millimeters. You realize right away that we're talking about generation of slices as a result of these very small voxels, that the thickness of which is going to be very small. It's going to be in the range of microns. So the detail of the resulting images is going to be very high. Medical CT acquires images in a different way. In this case, we still have a rotating source, as you can see here. Our X-ray beam is not conical in shape. In fact, it's fan in shape, and it's very thin. Actually, the thickness of this beam is going to be determined by us or by the operator of the machine, and this is going to determine the slice thickness. So every time the rotating X-ray source rotates around the patient's head, it completes a slice, if you wish, or a scan, and then as you can see, the patient's table is moving to a new direction, to a new area, so another slice will acquire, and another, until the entire imaging volume is going to be scanned. The result will be the same as ComBeam CT, right? We will still have voxelized, if you wish, the entire imaging volume. So we will convert that patient's head into very small pieces or three-dimensional voxels of information in order to assign a gray value. However, the process is a little different. I will show you examples of how these images will look differently very soon down the road. What both imaging modalities will accomplish, and it's something that is unique to our dental diagnostic imaging, is the multiplanar imaging or multiplanar reformatting. What does that mean? Since we have acquired an entire volume of information, as you can see here, we can very simply direct the computer of the device to select a layer only of voxels along this volume and generate an image. So if we want to really generate an image along this plane here, which is perpendicular to the patient's head, or axial plane if you wish, the computer will instantly generate a beautiful slice in that area, or if we wish, we can scroll throughout that volume in very thin axial slices. If we want to generate an image along the parallel axis of the along the long axis of the patient's head or the imaging volume, or in this plane if you wish, we will create coronal images that will look like that. Or again, we can scroll throughout the imaging volume with coronal images. Last, if we want to generate sagittal images, again parallel to the long axis of the imaging volume, however separating the imaging volume in a right and in a left part, then we will generate sagittal images or slices. And if you really do any kind of orthodontics, you would appreciate the quality in the identification of major anatomical landmarks in orthodontics as the sella, nasion, A point, or B point. Or if we want to generate the most popular image in dentistry, the panoramic radiograph, all we have to do is to really draw a curved line along the maxilla and the mandible. After all, this is what the panoramic radiograph is, a thick slice of the maxilla and the mandible, and the computer will instantly generate a beautiful panoramic image without any magnification, without any distortion, which seem to be the most common disadvantages or drawbacks, if you wish, of panoramic radiography. In fact, the slice thickness of this panoramic slice could be adjusted, and we can make it as thin as the voxel size that we acquired the scan, and as thick as we wish in order to include the entire volume. Or if we wish, we can really generate a series of slices which are going to be perpendicular to the mandible or the maxilla, as you can see here. And in these images we can actually estimate the alveolar bone height and width if we are planning on placing implants. Or we can ask the computer of the scanner to show us the entire volume and have beautiful 3D images like this, or like this, if we want to see the soft tissue of the patient's head. In these two cases, all we did was really to ask the computer to illustrate only those voxels in our imaging volume which demonstrate a density similar to that of cortical bone, as in the previous image, as in this image here, or similar density to that of soft tissue, as we can see as in this image here. So the multiplanar imaging, multiplanar reformatting concept brought a revolution to our diagnosis. In fact, now it is up to our fingertips, literally, to generate the kind of images that we will need in order to provide answers to the specific diagnostic task we are searching for. It is not really useful to generate a panoramic image or a few cross-sectional images to provide an answer to all our diagnostic concerns. We need to develop the experience to be able to generate this kind of images that, as I mentioned before, will provide this kind of answers to us. What we will try to do, we will focus on certain anatomical areas, including the neck, the mandible and maxilla, as well as maxillary sinuses. I would like to take this opportunity in order to encourage you to take advantage of the entire volume in full. Keep in mind that oftentimes other anatomical areas will be exposed outside of the very narrowly focused area of interest, and knowing our anatomy very well, it's going to help us diagnose or properly address other pathological entities that may be incidental findings. The field of view of the average cone beam CT machine, like the Kodak 9300, will be covering approximately the 2/3 of the patient's head. And a large amount of diagnostic information will be included in there, and these are going to be tomographic images, in other words, slices of the areas of interest. And as you very well know, sectional imaging or tomographic imaging is includes images that our profession is not very much familiarized with, and the main reason for that is the fact that throughout our training, most of the images that we used to review were planar, panoramic, or periapical images, and not sectional type of images. That makes the need of our anatomy, our anatomy knowledge even more advanced. Let's start our review here from the first area that we're going to address, which was the patient neck, and I will start with reviewing some of the most pertinent, well-recognized anatomical structures, and we will go gradually to more complicated anatomical structures. Usually the lower border of each cone beam CT scan will be at the level of the inferior mandible, and this is exactly what we see here. We're slicing through the lower border of the mandible on this patient. The other osseous structures that are readily identified are going to be the hyoid bone, and of course a vertebral body, as you can see here outlined, all of them highlighted in yellow. The vertebral body is most likely the fourth cervical vertebra. Very difficult to identify between the third and the fourth vertebral bodies. They look very similar. Now, the upper surface is going to be the ventral surface of the patient's body, of the patient's neck in this case, and the inferior portion of our sectional image is going to be the dorsal area of the patient's neck. You would recognize right away in the center of the image a very dark semicircular area which outlines the patient's airway. You know, air is always black on medical and on cone beam CT, and this is a structure that we can readily identify. Other structures that we will be able to identify, and I'm going to try to highlight back and forth between these structures, are going to be the sternocleidomastoid muscles, I'm highlighting now, major muscles of the neck, and of course the epiglottis in the identified in the middle of the patient's airway. The structures I'm reviewing are going to be anatomical landmarks to try to relate them to certain pathological entities. So bear with me on this review. You would recognize that muscles on cone beam CT are very hard to identify. Other muscles I'm outlining here, which are going to be the geniohyoid muscles. As I was saying, they were very hard to identify due to the fact that the soft tissue contrast of cone beam CT is not ideal for soft tissue imaging. Other structures that I'm highlighting now, and we can actually see only their silhouette towards the lateral border, here, and here are going to be the submandibular salivary glands, a classical structure belonging in the patient's neck, superior border actually of the patient's neck. So if we identify calcifications in a scan in that area, almost attached, as you can see, to the hyoid bone on either side of the airway, this may be cyaloliths, or calcifications in the submandibular salivary glands. This is an area of concern which is highlighted by this red ring. This area there, laterally to posterolaterally to the airway and almost tangential to the anteromedial border of the sternocleidomastoid muscle, this is the area of the major neurovascular bundle of the neck passes by, and by the neurovascular bundle of the neck, I mean the common carotid artery, the internal jugular vein, and the vagus nerve. And this is a really important area of concern because a great deal of atheromatosis may occur at that specific plane, as I'm going to show you very soon. This image is a medical CT scan in which we have injected a contrast medium into the patient's circulation. It's approximately at the same level as the image we were reviewing before, and you can see how much better anatomical structures like the sternocleidomastoid muscle, the submandibular gland, the geniohyoid muscles, the mylohyoid muscles are identified in comparison to the cone beam CT scan we saw before. I will draw your attention in the left side of this patient's neck where you can see just anteromedially to the sternocleidomastoid muscle two high density structures, which are going to be the internal jugular vein, the bigger one, and the common carotid artery, the one medially, and a little smaller one in diameter. As I mentioned to you before, this is the location, the area that these blood vessels come together with the vagus nerve. And I will also remind you that these structures show very well on the contrast enhanced CT due to the fact that we injected a dye. This area is approximately at the level of C3, C4 vertebral bodies, and it's quite important to be able, for us to be able to recognize it, simply because atheromatic disease will occur at that plane, and this is something that will show if the atheromatic material is calcified. It's going to show even on cone beam CT scans, as I will show you very soon. I would like to remind you that atheromatic disease is the leading cause of strokes in the US population above 60 years of age, and the vast majority of the atheromatic disease occurs at the common carotid artery at the level of its bifurcation, which really occurs, as I mentioned before, at the level of C3, C4 vertebral bodies. I'm just moving slightly upwards on this medical CT scan, the contrast enhanced cone beam CT scan, and you can clearly see that the common carotid artery is already split into the internal and external carotid arteries, and they are separated, split apart by the internal jugular vein. We have other blood vessels that clearly identified here, which is the external jugular vein laterally to the sternocleidomastoid muscle, and of course the vertebral arteries into the vertebral canals of the cervical vertebral bodies, along with the other structures that we were able to identify earlier, which was the geniohyoid muscle, the mylohyoid muscle, and the submandibular salivary gland. This is the 3D image of the previous case. And although you can see the very thick slabs used to really reconstruct this 3D image, you can clearly see how well the bifurcation of the common carotid artery is depicted and the internal jugular vein. And if we had the opportunity to count, we would see that this bifurcation occurs at the level of C3, C4 vertebral bodies. The same structures are depicted very well on the coronal image. The reason that the image looks demonstrates this stepladder effect, if you wish, is the fact that we used really thick slices to acquire this medical CT scan, something that would not occur with cone beam CT, since the slice thickness as a result of the very small voxel sizes used is always in decimals of a millimeter. I would like to draw your attention again in a direct comparison of an image of a patient's neck at the same level, C3, C4 vertebral bodies on cone beam CT scan on the right, on your left, and medical CT scan on your right. You can see that on the right, although it's a medical CT scan without any contrast enhancement, you can see again that the soft tissue contrast is depicted much better in comparison to the cone beam CT, and in fact the major blood vessels of the neck can still be identified on medical CT, although on cone beam CT all we can identify the general region that the blood vessels will be, and again due to their relationship with the anteromedial border of the sternocleidomastoid muscle, and not due to the fact that we actually see the blood vessels of the neck. One of the reasons that the soft tissue contrast is so much better with medical CT is obviously the fact that medical CT uses a much higher radiation and is able to depict a better soft tissue contrast. This is an example of carotid atheromatic disease, carotid atheromatosis in the common carotid artery. You can see them depicted right in the area where we were seeing the blood vessels before, just anteromedially to the sternocleidomastoid muscle and laterally to the airway. As you can see here, on the a large portion of the lumen of the blood vessel is occupied by the calcifications, and actually on the coronal images, which is here on your right, you can see almost the lumen of the blood vessel depicted by a calcification. The calcifications on the right side of the patient's neck are not as big. This is certainly a reportable radiographic finding which may pose a liability for the dentist if this is included, if the scan includes the carotid arteries and such a pathological entity is not diagnosed and properly addressed. So I would really like to tell you that in this case here, this was an incidental finding. In fact, this was a case for mandibular, which was done for mandibular dental implants. Next case I'm going to show you is another example of a carotid artery calcification, again in its same location, almost in contact with the anteromedial border of the sternocleidomastoid muscle, much smaller though than the calcification we saw before. Again, almost the blood vessel of the lumen of the blood vessel is depicted in this calcification. The common carotid artery favors the accumulation of atheromatic plaques, mainly due to the fact that the blood vessel is splitting at the level of the bifurcation, and these changes in the blood flow may really attract the formation of plaques in the region. As I mentioned to you earlier, one of the most reliable landmarks, anatomical landmarks to depict the bifurcation and therefore the possible calcification is the level of C3, C4 vertebral bodies, and you can clearly see in my picture here that the calcification really is identified in the space, intervertebral space between C3 and C4 vertebral bodies. The cervical spine also shows on our cone beam CT scans of the mandible, and this is how we want the cervical spine to look. The vertebral bodies look almost trapezoid or rectangular structures. You can see a very straight line formed on the dorsal aspect of the vertebral bodies, which means nothing is really dislocated or protruded into the spinal canal, which is depicted by this low in density region. I would like to remind you that the spinal canal is the location of the spinal cord. Now, sometimes the shape of the airway is altered, is affected. And I would like to draw your attention in our axial image here, where you can see that soft tissue masses really bulging into the airway and shift the lateral walls of the airway medially, actually restricting the airway considerably, as you can see here in my sagittal image along one of these soft tissue masses. This is bilateral tonsillar hypertrophy, most of the times inflammatory tonsillitis, if you wish, which may restrict the airway significantly, and these patients may present with symptoms of sleep apnea. This is something else that a lot of our colleagues lately addressed, and we can analyze the patient's airway very well by cone beam computed tomography. Further higher, some other type of calcifications may occur at the patient's mouth, like this cluster of calcifications we can see on either side of the airway. We can identify, we can be sure that these are not vascular calcifications due to the fact that we're slicing much higher than the carotid bifurcation. In fact, you can see that we are slicing through the patient's teeth. So these structures here, these calcifications, really are present at the level of the floor of the mouth, and these calcifications are very, very benign and appear to be tonsillar calcifications. Repeated inflammatory changes in the tonsils may result in this kind of calcifications, very, very benign calcifications that should not pose any threat for our patient. And of course, sometimes other much larger calcifications may occur at the level of the floor of the mouth. You can see here almost a pear-shaped large calcification. You can see how it is depicted on the axial, sagittal and coronal images, almost in contact with the inferior border of the mandible at the level of the mandibular angle. If we can see it in a higher magnification, you can see that its location is almost a textbook location for a submandibular gland sialolith. This is the exact location of the submandibular salivary gland, medially and inferomedially actually of the mandibular angle. So this was a large sialolith, which was an incidental finding in this patient. Heading higher, we're going to start reviewing the mandible, and we will focus in our review of the mandibular bone mainly of the evaluation of the mandibular canal. As you know, the mandibular canal is poses a major anatomical limitation in placing implants on the mandible, and its identification is really crucial for implant planning. The mandibular canal sometimes shows very, very well, as you can see in this case here. In fact, to how well it's going to be visualized is really linked to if there is a well-defined or a well-corticated border around it. However, not all cases, not all mandibular canals are visualized very well. And this is another example of a mandibular canal that, as I'm showing you in a higher magnification, it doesn't show very well. It still is fairly well identified, but it's not well delineated, simply because its corticated border its border is partially only corticated, and in fact it's almost impossible to distinguish the mandibular canal from other structures that look alike as large and wide bone marrow spaces. And of course there are always going to be cases like this, that the mandibular canal, as you can see, is nowhere to be found bilaterally. It shows somewhat to the right mandibular ramus, but if you can see even sectional images, the mandibular canal does not show at all. The literature shows that even with the best imaging modalities available, as cone beam CT scans and medical CT scans, there is a chance of approximately 4 to 5% that the mandibular canal will not show. And this is simply due to anatomical variation and for no other reason. I would like to remind you again that if the mandibular canal does not have a corticated border, it's going to be impossible to identify it from other anatomical structures that look alike as bone marrow spaces, etc. This case shows you the ramifications of the mandibular canal not clearly identified into a cone beam CT scan or into other type of diagnostic images. The misestimation of the alveolar bone height led to the dental implant not only perforated the superior border of the mandibular canal, but going through the mandibular canal and through the inferior border of the right mandibular canal, with the known consequences into the patient's, and which is the inferior alveolar nerve damage. Another significant anatomical structure that we may see into the anterior mandible, actually on the lingual aspect of the anterior mandible, would be another opening into the lingual aspect of the mandibular bone, which appears to be a very significant vascular canal. This opening is known as the lingual foramen, and it accommodates terminal branches of the lingual artery. This is the lingual foramen, as I mentioned before. Terminal branches of the lingual artery go through that and provides supplement blood supply to the mandibular bone. And although its normal location is fairly low, if we have considerable atrophy of the alveolar bone, you can see that the lingual vascular canal is maybe in our way when we're planning for dental implant placement. If this vascular canal has considerable diameter, it may bleed significantly, and this is something that we need to keep in mind and be able to identify in order to avoid that location if it is identified in our scan. If its diameter is less than 1 millimeter, the literature says that the bleeding is not going to be significant. This is a literature citation I'm quoting for you in regard to the above matter. Lingual canals were present in 97% of the cases and accessory lingual canals in 34. Larger than 1 millimeter in diameter canal may cause major hematoma on the floor of the mouth if injured during implant surgery, as it is quoted by this group of Austrian surgeons. In my judgment, even if we didn't have all the other anatomical limitations of placing implant in the posterior mandible, only the alveolar ridge variation is a good enough reason to have a cone beam CT scan in most of our implant cases, if not in all. You can see in this image here that we have no problem with the alveolar bone height, right? You can see that we have a major undercut in the middle third of the alveolar bone towards its lingual aspect, which may pose a threat while placing dental implants. And you can see this undercut is in the premolar region. You would recognize the second mandibular premolar. So it's in an area that we would like certainly to place an implant. So although the alveolar bone height is considerable, the width of the alveolar bone is greatly affected by the location of the this significant undercut. I will give you one example of significant pathology that may occur in the mandible, which was a really impressive case. I always worry, and I would like to draw your attention on this, whenever I see this kind of erosive lesions, erosive appearance of the mandibular bone, especially on its lingual aspect. This is the floor of the patient's mouth, this is the patient's cheek, this is the crest of the alveolar bone, this is the lingual aspect of the mandibular bone, and this is the buccal aspect of the mandibular bone. There is a large erosive lesion which appears to have originated from the floor of the mouth, and it's growing into the mandibular bone. These are lesions that need not, that it's absolutely imperative to be diagnosed. It's really unforgivable to miss such a lesion, and we may be liable for something like that, if especially if it is as an important finding as this. This actually was a large this was a soft tissue mass, in fact a squamous cell carcinoma on the floor of the mouth, that you can see that it's invading the mandibular bone. As you've noticed so far, we started from the lower part of the scan. We discussed about anatomy and related pathology of the neck, then on the mandible, and now we're moving towards the maxilla. In my slide, I am illustrating now the difference between an axial image made with cone beam CT on your left, as far as concerned the soft tissue contrast, in comparison to the medical CT on your right. You can see the much higher soft tissue contrast on medical CT in comparison to the cone beam CT, and as I mentioned in the past, this is mainly due to the larger amount of radiation that it's being used with medical CT. However, the detail on hard tissue is not that far different. Towards the superior end of the maxillary alveolar, towards the base of the alveolar ridge, we are identifying two small radiolucent anatomical structures on either side of the hard palate towards the second molar region, and that's how these structures look into the cross-sectional images. The anterior-most structure is the greater palatine foramina, and the smaller one on the back are going to be the lesser palatine foramina. The structures highlighted, identified with the green arrows on the axial image, are the greater palatine foramina. They provide passageway to the respective nerves and blood vessels, and if you were trained as an oral surgeon, you would be told to never ever do vertical incisions on the palatal aspect of the maxillary second molars, because there is a risk to section the greater palatine artery. Now we are further up, and we can clearly see the right and left maxillary sinuses. My small image on your right illustrates, demonstrates the level at which our axial slice has been acquired. The maxillary sinuses, as I said already a couple of times, are filled with air, and air is always black on medical and cone beam CT scan. So in healthy anatomical structures, in healthy air cavities, we want them to look black. Anything but black may indicate disease. I would like to show you how much the shape of the airway is altered as we go from bottom to top. And going back to my previous slide, I would like to show you the characteristic, almost star-like appearance of the nasopharynx. This is towards the superior end of the airway. This is a normal appearance of the airway. However, sometimes you see that the shape and size of the airway may be affected by soft tissue masses. In fact, we in radiology, we try really hard to memorize the normal shape and size of certain anatomical structures, and when this is altered or its shape is shifted or their walls are shifted by any means, we instantly are suspicious of disease, as is in this case. As you can see in this case, almost a a large mass originating from the nasal cavity appears to be projecting into the airway, into the nasopharynx, and actually it's affecting greatly the shape of the airway. And if we magnify our image a little more, you can clearly see that this mass has almost completely obliterated the nasopharynx. The patient actually had a hard time sleeping in a supine position because this mass would obscure the airway completely. This was a large nasal polyp which was causing a significant sleep apnea on this patient, and this was diagnosed on a cone beam CT scan for a dental implant assessment. So knowing your anatomy, as I mentioned to you, is going to really contribute to providing a better service to your patient, simply because it will improve your diagnostic efficiency significantly. My advice to you is to always review the maxillary sinuses in any kind of procedure you're planning to do in coronal images. Coronal images are the best views for maxillary sinuses, and I will review the anatomy of the maxillary sinuses here in a series of coronal images starting from front to back. In my images here, as you can see, I am towards the anterior third. I'm slicing coronally towards the anterior third of the patient's face, and I can see the maxillary sinuses in all their magnitude. As you can see, the sinuses look like trigonal pyramids, with their base being the medial wall or the lateral wall of the nasal cavity, and you can see the draining site or the osteomeatal complex of the sinuses as this very thin, delicate tube-like structure. If we magnify our image, we're going to see that the sinus really drains through this very, very narrow opening that I'm highlighting here, and these dotted lines provide the passageway of the draining into the middle nasal meatus. Would like to remind you that the maxillary sinuses, a large number of the paranasal sinuses drain into the middle nasal meatus, and in fact that they drain very close to one another, and this may easily transfer inflammatory changes from one to another. Again, I would like to draw your attention to the fact that black appearance of the maxillary sinuses or any paranasal cavity is a healthy appearance. And this is a maxillary, these are two maxillary sinuses that they do not look so healthy. As you can see, they do not look black. On the contrary, we have accumulation of gray, soft, if you wish, in density tissue throughout the maxillary sinus cavities. We have a dental implant here which may have perforated the floor of the right maxillary sinus, and you can see a soft tissue mass which has originated from the roof of the right maxillary sinus. This may be a polyp again, a soft tissue mass indicating chronic inflammatory changes. On the left maxillary sinuses, we have a simplest type of inflammatory response. We call it thickening of the mucosal lining, or mucositis it is called in some books. This is the earliest of the stage in developing inflammatory changes, often seen also in allergies, even seasonal allergies in some patients. An example of a left maxillary sinus which is completely blocked by inflammatory tissue, and you can see that the draining site, its osteomeatal complex, it's really blocked. So this is the most severe type of inflammation, acute, if you wish, inflammatory changes that may occur in a paranasal cavity. Another example of acute inflammatory changes that developed very, very fast, as you can see from my scout image, and you had realized by now that I'm using a variety of images originating from several cone beam CT scanners. We have some implants placed in the left posterior maxilla, and a few days later the surgeon realized that he has a severe acute inflammation in the left maxilla maxillary sinus, which now has eroded the medial wall of the maxillary sinus, and it's growing into the left nasal cavity. All this because of a very, very small fragment of the maxillary sinus graft which gotten loose during second stage surgery, and now this has caused a tremendous inflammatory response which would require a hospital stay to be treated. In my slide here, I'm showing you an odontogenic in origin cystic lesion. Actually, this was a radicular cyst or or a periapical cyst. This cyst originated most likely from teeth 14 and 15. As you can see, it has grown quite big. It has displaced the floor of the left maxillary sinus superior. However, you can see a clear hyperostotic border separating the cystic lesion here from the maxillary sinus, which means although the maxillary sinus floor has been displaced superior, there is no invasion of the cystic lesion into the maxillary sinus cavity. Another example here on inflammatory changes, not very extensive, into the right maxillary sinus, which however is of odontogenic origin. I would draw your attention in the apical region of tooth 2, which, as you can see, demonstrates a periapical inflammatory lesion, which if you follow slice by slice in the cross-sectional images, you're going to see that you lose the cortical outline of the periapical inflammatory lesion, which means that this lesion has eroded the floor of the left maxillary sinus and may be responsible for this inflammatory response into the left maxillary sinus, or at least we cannot rule possible odontogenic origin of this periapical inflammatory lesion. I would really close this part of my presentation again with this strong statement. Please do the right thing and make sure that you evaluate the entire volume. Reviewing only the structures you know is wrong. This volume, even the smallest volume on a cone beam CT scan, includes a lot of information that we either have to be familiarized with continuous training and learning about this, or you have to seek the assistance of an expert. Having that said about the importance of knowing your anatomy and being able to review the entire volume, I would like to very briefly address some of the responsibilities in handling a cone beam CT volume or using this kind of advanced technology. A lot of discussion has been introduced lately about possible responsibilities in reviewing cone beam CT volume, or possible liability issues if something is missed in a cone beam CT volume in an area which was not our initial area of interest to begin with. Several states have started already making statements and trying to provide guidance to to the dental professionals in those states. One of the very first issues that came by was the fact that some of the cone beam CT manufacturers would provide the dental professionals with pre-made consent forms, or if you wish disclosure statements, in which in a way it would say, my doctor such and such has made this scan in order to evaluate tooth 30, for example, for a dental implant. If something else is included in the volume, my dentist is not responsible, etc., etc. This was brought to the attention of several dental boards, and some of the dental boards, like the Dental Board of North Carolina that I have here, made really strong statements about it. The board urges you to consult your legal counsel for advice before risking exposure to potential liability if you use this kind of consent forms. And in fact, the board makes even stronger statement clearly saying, if you acquire a volume of data, you should be able to interpret the data for a complete and accurate diagnosis. If you are unfamiliar with the full potential of this emerging technology, you should consider consulting with a board-certified oral and maxillofacial radiologist. And I think myself, as the executive director of the American Academy of Maxillofacial Radiology organization, I would really try to urge you to do the same thing. We are not saying that all the scans need to be read by a maxillofacial radiologist, but certainly need to be reviewed by somebody who is very much familiar with and experienced with. If you don't want to have the risk or the liability for something like that, maybe you should go work closer with a maxillofacial radiologist. I will continue this discussion with a document published by OMSNIC. OMSNIC is the Oral and Maxillofacial Surgery National Insurance Company. It is the biggest liability insurance company in oral surgery. And in fact, they made pretty much the same statement. The oral surgeon cannot have the patient sign away the liability for not diagnosing a soft tissue cancer on the other side of the mouth. So in a way, we are liable if there is something in the scan, even if this is in a different area than initial area of interest. A cone beam CT scan taken in the oral surgery office is no different than a panoramic film or any other film. The oral surgeon has a responsibility to read the entire film or have it read by a radiologist. So please keep in mind that if OMSNIC, the biggest liability insurance company, says that there might be some merit on this, or we may have to look into that. And in an office cone beam CT scan, the same document continues, is no different than a hospital CT radiology center or based CT or MRI scanner. The scan must be read and interpreted, and a copy of the report maintained in the patient's record. And I continue with a different document, the American Association of Orthodontists Council of Scientific Affairs, that published a very interesting editorial, which I have here. In this, they addressed some really common sense issues like, should all scans be read in their entirety, and if so, by whom? Is the cost of reading of a cone beam CT scan included in the fee for taking the scan, or it is additional? Do patients have any choice regarding the degree of interpretation recruited? How is this problem handled in medicine? And actually really try to address it in a very, very nice way. And they close with a very interesting statement. It only makes sense that as specialists in orthodontics, we understand when to refer our patients' cone beam CT scans to specialists in radiology for the best possible care. So in a way, and that's how the AOMR, the American Academy of Maxillofacial Radiology, feels that we will reach a level as we grow experience with this that the dental professionals will become more and more familiar with this technology, and there will be a certain degree of difficulty of scans that will be referred to a maxillofacial radiology. There will always be going to be a group of physicians that may not feel comfortable, or they don't want to have the liability to do that, and may send all the scans to radiology. But it's all in the end, everything is the result of really it is related to our responsibility and to our professional judgment. So if until now still wondering what to do, how to handle those scans, if I still have to interpret all my scans, do I have to maintain a written report, etc., I would advise you befriend your oral maxillofacial radiologist. This was actually the topic of that editorial I just mentioned to you earlier. I would like to really thank you for your attention. This is me. This is my email. Please mark it down and contact me if you have any questions. I would like to invite you all into a much larger, much wider course like this that I will present in the November International Carestream Symposium, which is going to be really interactive with audience participation on interpretation of cone beam CT images. And feel free to contact me if you have any question or any concern, or for any other reason. Thanks a lot for your attention.